So when I began, I started to talk about the profile of this neighborhood as high poverty, high disadvantage in many ways. The other side of the story for this neighborhood is that when we started to talk with them, they said, if you want, like you researcher, you pediatrician, you health professionals want to come to work with us, you have to engage with us as partners. So our partnership is very much recognizing the kind of expertise that our young guest who was in the video this morning, if I had to live for 2 months on the street as a 15-year-old, I would have a great challenge doing that. So this community is a community that had already identified as a priority for them, they wanted to have successful children. So they had already started to mobilize around getting in place childcare programs for the children in their neighborhood that were accessible on their minimum wage or on their benefits stipend. They had already developed community boards for their organizations who had input into the ways priorities were going to be set. So they said, if you want to work with us, you're not just bringing health services to fix us, we're going to do it in a way that works for us. So one of the first kinds of innovation in our project is, in a sense, we took the idea of the table that Gilles enacts with his families, and we have, for the last 7 years, met every week at a table. This morning would be the table. And this is a place for the community voluntary organizations to come, as well as the people from the different professional, so from the Children's Hospital, from public health, I come as a researcher, the teachers from schools come, etc. So it's a way for us to keep connected around what's going on, what's working, what's a new issue that we should be thinking about. So that's where the R in response, in richer comes from, is this being responsive in making it work. So that table also helped us deploy the resources that we had. So I could formulate an argument as a researcher to the Children's Hospital, to public health, to say we need to do something because there's no healthcare access, there's huge health challenges. So they agreed to give us support, so I could write that kind of an argument for that. But the how to put those people in place was the piece that we work with the community. So that's one piece of the innovation. And the other piece is this when we talk about partnership, we usually, as people from institutions, talk about partnering with institutions. And here the partnership is with people. And the key idea that the community reminded us of, that fits with Gilles' work, that fits with the population studies around who are the children that survive or thrive despite being exposed to multiple adverse childhood events, the ACEs, are the children who have ongoing, enduring relationships. So the goal of this model was to position the clinicians to work to ensure these children had ongoing, nurturing relationships with whomever were the most appropriate people. So those are two reasons why there's R.
After the health disparity study was published and people came around and sort of the study results were presented to numerous organizations, including the community, and the community was sort of at the center, saying that they identified access to services as one of the biggest barriers, and access means lots of things, and I'll talk a little bit later about that, but then also identified the school as a safe place in which to receive services. And this is from a largely, Saskatoon's core neighborhoods, a largely indigenous population, and if one understands the history of the residential schooling system, it's really interesting that the school at this point is still identified as one of the safe spaces, which is a testament, I think, to the education system. So the partnership with the Department of Pediatrics, and I think from the department's perspective, we are fulfilling our role with regards to social accountability in a very, very meaningful way, in a manner that is often overlooked in medicine, I think. In doing that, we are the social pediatrics model in the school-based health is part of the residency training program. And I want to emphasize that it's really, really important for us to train postgraduate students, residents, not just in pediatrics, but from some of the other departments. And also in the undergraduate program, so medical students have an opportunity to come through the school-based clinics. In fact, it's mandatory for them to come through, as it is mandatory for our residents to come through social pediatrics and school-based clinics. And what it means is we are exposing learners to an alternative model of care. We are allowing them to work with more diverse populations in a manner that is more meaningful. We are teaching residents about health in a manner that is different to what is taught at the hospital. I think when residents come into, and when medical students come into the core neighborhoods, and certainly for the residents who are there day in and day out for a 4-week block, they have to come through the neighborhood and they have to learn and understand what it means for people, for infants, children, and youth who come from families who are poor, to live in neighborhoods that are plagued by poverty, and the dual and compounding effects of family poverty and also neighborhood poverty. I think one of the things that we do in the school-based health clinics is how our residents can learn, and certainly how I can learn, to establish relationships with people where we decrease the power differential that exists between us, and the power differential that exists between us by virtue of our education, by virtue of the clothes that we wear, our income, our vehicles. And doing this in a school is, again, it's teaching residents that there is a different way to do things, and certainly acknowledging that we are privileged and we have to acknowledge this. The partnership with the Saskatoon Tribal Council is absolutely necessary. It's not just important, it is necessary. Again, in Saskatoon, when we look at the population demographics, and particularly the population that lives in poverty, Indigenous people are disproportionately affected. 15% of Saskatoon's population is Indigenous. More than 50% of the population resides in Saskatoon's low-income neighborhoods. We need to acknowledge the history, the politics, the economics, and the bad policies that have led to the status quo. And that is something that we try to highlight in the clinic and within school-based health. But this is why it's absolutely important to have the Saskatoon Tribal Council as a partner. And they provide the medical administrative assistant to the clinic and also funding for some of the programs and pieces of equipment. The school, why the school? Well, because the community identified it as a safe space. When we're talking about the determinants of health, everybody talks about income, and so we're in the core neighborhoods, which is low-income Saskatoon. But health is education, and education is health. Education is your ticket out of poverty in many, many respects. The schools is a safe space. As I said earlier on, it is a space that is familiar for people, where people feel less threatened in talking to individuals who come from, in Saskatoon, across the river. And one of the most important things I think that the school affords us is to address the intersection of the other sectors that influence the well-being of children. And I think that was illustrated really well in the clip of the movie we saw this morning, looking at Maxime's life. Maxime mentioned child protection, police, the education system. Health was not mentioned, even though we know the potential for ill health is there. And so it really affords us to work with those sectors in a meaningful way. And certainly that intersection happens a lot more in schools and in the neighborhoods than it does over at the University Hospital, which is where my office is. I'll stop there for now.
Mrs. Desharnais, after hearing that, I'm struck by the fact that you are present in two different neighborhoods. So this is not, your approach is not school-based. Is it first and foremost medically based? Well, it's integrated. Of course, there are two different realities, two neighborhoods, but the approach is the same. We're talking about an integrated approach in Hochelaga Maisonneuve. The difficulties are transgenerational, as we say. And the other neighborhood, this is more of a transitory poverty situation because you have more recent immigrants living in that neighborhood. But the idea is that the intervention is centered on the child, how we were talking about partnership, about community, how everybody will intervene and work with that family, not to impose anything on the family, but also be open. We're talking about being open to the families, not to judge them, to really treat them as equals and not act as experts.
You know, everybody in this room agrees that we should be investing in prevention, that we should understand the social determinants of health when we talk about health and think about health. And we talked about how, Jeff Kazrowski, my colleague, brought up that this is going to require a paradigm shift that could take years and years. And I do totally agree with him that it is about a paradigm shift, and that the way you get that shift to happen is by training people. And so the medical students in the room who are going to be the next generation are going to be the leaders of making this change. Because the reality is, even though all of us in this room agree with prevention and social determinants, that, especially in the United States, even more than in Canada, we don't have a health system. We talk about a health system. We have a medical system, which is a sickness system. And very little is devoted to preventing. Very little is devoted to going upstream. And we talked earlier this morning about, why don't we do these things that work? And it's because people don't know about them. And people don't know about them because they never even think of them, because they don't go looking for them, because it's outside of their paradigm. It's outside the biomedical model of what causes disease. And so if we're going to shift the system that we have, the people that we have who are interested in making people healthier, that's why they become doctors, into having a broader perspective that includes community health, that includes social factors, we've got to change the training. And so how do you change the training? And what we just heard up here is one of the basic things is you've got to get people out of the hospital. If you spend your entire training in a quaternary care center, in an academic research medical care center, you're getting further and further away from the community. And what was common sense to you before you started your education disappears. And so we need to figure out how we teach community health to physicians. And that's what we've been doing with PLC Care. And we've started with pediatrics residents, and since then we expanded it to family medicine residents, internal medicine residents, nurses, medical students, psychologists, other kinds of people, because everybody can use this kind of training. And so as part of the Dyson Initiative years ago, which was an experiment in creating this kind of training across multiple sites in the US about a decade ago, there were lots of questions at the beginning of how do you do this? Should it be required? Should it be elective? Should it be at the beginning of training? Should it be at the end of training? Should it be in a block? Should it be longitudinal? Should it be about research? Should it just be about learning? Should it have a project, or should it be following somebody else? And the answer to those questions is yes. That it should be all of those. So we have, in our model in Rochester, we have a mandatory element early in training, which is what the PLC rotation is. So everybody goes out into the community for 2 weeks, sort of like the rotation you heard about, where everybody goes out for a month. We send people to 10 or 20 different sites that they, for the most part, don't pick. So they learn about a whole bunch of different things. And they get 3 main things out of that mandatory 2-week rotation. The first thing is that they learn about community-based organizations that exist, that they didn't even know existed before. And they see these people who are like angels, who are helping the children who have the greatest need, who are not otherwise being taken care of, who are falling through the cracks. And they realize that things are not as hopeless as they thought they were. And it changes the way that they practice. Because if you see someone coming in to your clinic or who's admitted into the hospital who is a child who is not getting enough food, or the mother is being beaten, or the family is homeless, or all kinds of things that we've been talking about today, and you have no idea what to do about those problems because there's not something in the computer prescription gizmo for what to do about that, then you're not even going to ask about it. Like maybe you'll notice it, but eventually you'll learn not to notice it because there's nothing for you to do about it if you do notice it. And you don't have a lot of time because everybody's super busy. And so you eventually wind up not even asking about it. But if you've been to the site in the community that really helps people who have those problems, if you've been to this amazing food bank that we have in Rochester that gives hot meals to children and that has a kitchen program for teaching people to cook and that has organic vegetables and has all these other different things going on about hunger and nutrition, then you go, oh, well, that's not a big deal. If this family doesn't have enough to eat, I know what to do about that. I know where to send them. If you're worried that maybe there's domestic violence going on, if you've been to the battered women's shelter and you know that they have a wonderful program that protects the women and you've seen that, well, now you can ask about that because now you have something to do about it. So that's the first thing that people learn just from going out into the community and just seeing what's there. The second thing that they learn, which we already heard a little about from the Saskatoon program, is the lived experience of poverty. Most residents come from a middle class or higher background, and they have not seen people who live in poverty firsthand. They have not, one of the stories we've heard is one of our residents said that she always grew up that she was taught to pick yourself up by your own bootstraps. And so, poor people, it's sort of their fault they're poor. And she went and did these rotations and realized there are people who don't have bootstraps. So how are they supposed to pick themselves up? And it completely changed her life, and she wound up becoming a medical director of an inner city community health center. So lots of times you can have a radical change in people's attitudes, which changes their personal paradigm and changes what they do just with a change in exposure. But it does have to be an experience. You have to go out. You can't just read an article or see a PowerPoint about it. You've got to get out into the community and experience it. So that's the second thing that people learn. The third thing that people learn from our required rotation is in some ways the most moving, which is that what they tell us is that they remembered why they became doctors. And if you think about that for a minute, these are first-year residents. And if they're remembering why they became doctors, that means they've already forgotten, because you can't remember if you hadn't forgotten it already. So what is going on with our education of medical students that they've forgotten why they become doctors? And who wants to go to see a doctor who doesn't know why he's a doctor or why she's a doctor, right? You don't want that. Nobody wants that. So we can put the fire back into these people, and they're going to deliver better medical care. They're going to be happier with themselves. They're going to do more to take care of kids. And then some of them get on fire so much that they decide they want to do more. They want to go do a project in the community. They hear about there's violence in the community. For a while, Rochester was the murder capital of New York State. It's not something we're proud of. But we were, and so there were a bunch of residents who wanted to do something about that. Well, what do you do about that? Well, normally that has nothing to do with being a doctor and learning how to be a doctor. But the residents who go through our program, they learn that there are things that you can do that are evidence-based, that help to prevent violence in children, and you can give those to kids in the schools. And one of our teams of residents brought an evidence-based program to the city school district. And it's crazy when you talk about it. Why do young doctors need to partner with the schools and partner with the YMCA and partner with these other community agencies to bring a prevention program like that to a community? But they did, because nobody else was doing it. And that was 7 years ago, and now it's in 17 schools in Rochester, and it's helping lots of people, and it's changing lots of lives. And it's helping the whole school, not just the kids in the program, it's helping the whole community. So we know that we can teach this. We know that people want to learn it. We know how to teach it. And what I'm most proud of is that we've been doing this long enough now that people who have gone through our training are now going off to other medical schools and replicating our program and starting it over, teaching it to other people in other sites. And so we know that we can spread this. And we'd like to figure out how to spread it even faster and spread it to whoever needs it in Canada too, who doesn't already have it. But we know it can be done. So let's do it some more.
In fact, results are quite obvious because social pediatrics is a long-term trajectory. We're at the second generation. So the children we were treating now bring their own children. So now because of those connections, we're very present. But the idea also is to adapt and to really know the community's needs and what services to set up for vulnerable children. For example, the alley project, the Ruelle project, in that area, there's an alley, and we realized that there was no safe place for the children to play. And under the Convention on the Rights of the Child, they have to have a safe place to play. So we decided to give back that alley to the children. So we went and found partners, we engaged the community, and we gave back the alley to the children. And every day during the summer, over the weekends, during the school year, they're supervised by educators, and the goal is to give their neighborhood back to them, to empower them also through that program. We have also several other programs that we launched but that were interrupted because the needs were not there anymore. For example, Baby Kangaroo. We started that project because as many young mothers would give birth in the hospital, and a day later they had to be home. They were sent home. So we had to avoid problems later on. We talked about identification with the environment, so we have to maintain the parental skills of these people so that they may keep their children with them. So we started this project, Baby Kangaroo, with parents with very young children from 0 to 12 months in order to foster attachment between the child and the parent. And after 1 year, not one of those children had to be placed by youth protection. So this is really our model. We really have to take the pulse of the community. That's why you have to be engaged. You have to know the families, the members of the community, and start the project where it is needed. That's what we were talking about, this bottom-up approach.
We've actually had 3 different research grants that we're working on our project, and a 4th we hope will come. But when we started, the first thing we set, so we've used different research methods, so qualitative methods and standardized quantitative methods in order to try and dialogue with the different people that want to hear what the outcomes are. But we've also used a perspective that pushes us to step back and say what's really happening here, right? So not just what it seems to be happening, that these are disadvantaged families or black families or whatever, and so therefore that's the problem, like what really is operating. So the first thing we tried to do was really tease out why do we have the profile that we have in this neighborhood? What are all of the things that are operating here? And what are the things that we as professionals or as community members or as educators might do something about? And all of that probably wouldn't be surprising to any of you, but it is important to sort of try and come to grips with it, because people hold ideas about people. It's just, they just aren't organized. So if they just organize themselves, everything would be fine. Professionals say in Canada, we have a universal healthcare system, so there are no problems with access. But then you find out that they're afraid to go to a clinic because these people have in the past taken their children, or they have the power to take their children. So the issue of access isn't just about where the services are, although that's part of it. It's also about who are the people that I'm going to engage with around whatever that service might be. And so the concept of safe place was really important that we heard, and the concept of not being prejudged on the basis of my ethnocultural background. So these are ideas that we then were able to take into how we made our plan. So the next thing we tried to do was talk about the processes in our next study. We talked about what are the ways that, what does this look like from the family's perspective, from the clinician's perspective, from an organizational perspective? Because when we say clinic, most people think of the clinics that we all go to. And this kind of clinic has people who have clinical skills, but it's not all sterile. And so what actually has to happen? What is the nature of the relationship that person establishes with the person? And then for us, it was also, what's the kind of work? What actually happens here? So some of it, typically what we learned is it's the continuum of care from, I use my hands a lot, so I hope it doesn't distract you. The continuum of care from social determinants of health, I guess for you it's this side, to specialized services. So it's one thing if your child has a sore throat or an otitis or a runny nose, but if your concern is I have to get to the food bank before it closes, then you make decisions on the basis of what's going on for you. Or if your concern is that your housing isn't working, yes, your child has a seizure disorder and perhaps hypertension and didn't get a follow-up from the cardiac surgery that they had, but right now we need housing. So what we found is in the organization of the way the clinicians worked was to call this person who works in the community organization that deals with housing and call this person in who they knew already and say, well, can you deal with the food thing? We're going to deal with the seizure thing. And so these are all people that they know. And so then all of a sudden the physician or the nurse practitioner are doing what they do best without dismissing the other things that were of higher priority or more important. I need to deal with my child's teacher. Can you help me deal with my child's teacher so they understand her behavior? So our nurse practitioner goes, is in the schools. Our nurse practitioners are in the schools, in the daycares, in the community centers, and our pediatricians meet up with them in those places. So it's all where those families feel safe. And what I use the term, I don't use it, I guess, because I can't remember it, but there's a word I use where you're a convoy. So different people are convoys to the appropriate collection of services to support that child and family. So we tried to tease out what is the nature of the work, and therefore who do you need at your table. And in our case, the table, We started with no money. We started without a foundation. We still don't have a foundation. We still don't have any money. But what we do have, and I think this is all of you in the room have this, you have your own capacity as a professional or as a person with knowledge and skills to say, this is best practice, I'm going to do it this way. So we had professionals and teachers, like people from all different sectors who said, my concern is how can I work most effectively with these children? So I will come and work with you. So we did get buy-in from institutions to say, we'll give you some people, but all of the rest of it was negotiated from the place that the organizations already had the mandate or the resources. It was how we deployed those resources. So Richer is a virtual social pediatrics program in some senses. It is a program of the hospital because the nurse practitioners and the pediatricians all have appointments with the hospital and many with the university. But in a sense, we didn't start by saying we need a building, we need a space. We started with people who wanted to collaborate. So all of that. So our research. So in the research so far, we did those things, and then the other concepts that we studied that we measured. One of the key issues was access. Do these children and families, are we making care accessible? So we measured that using a standardized measure of primary health care access. What are the outcomes? So the outcomes that were most important for these families and of the greatest significance for our outcomes was the nature of the relationship they had with the health professional. So does that person involve me in decisions? Does that person help me to understand what's going on? Does that person partner with me in the way care is provided? Those were all really important dimensions of the skills that were valued by families. And then the outcome that we measured, because these are children with all different kinds of challenges, not just one health condition, we looked at empowerment as a measure of the capacity to manage your child's health condition, to make decisions, to talk to people about it, etc. So the capacity of the parents to do that, their own rating of empowerment correlated exceptionally highly with the relationship between the providers. So that tells us something about what is it that professionals need to be able to do and with what effect. And we're now trying to examine what's needed to establish a medical legal, like what is the whole range, what's the best way for us to move that agenda forward. So I think we're doing something else, but I can't remember now. So all that.
I think, I know that research is exceptionally important. It is necessary. However, when we started the school-based clinics, we were really, really cognizant and very careful not to do that at the onset. People do pilot projects, particularly in poor neighborhoods, all the time. Poor people are researched to death, and outcomes have not changed. And so we were cognizant that we needed to earn the right to do research on the work that we were doing with a population that really provides me with a job. We did, however, we had set ourselves some goals, some really modest goals at the beginning, and as I said, one of them was access to care. And if we look at where we were then and where we are now, we started with a pediatrician. We really were looking at establishing services that were going to be multidisciplinary. We have a registered psychologist, a clinical social worker, we have an optometry clinic, we have a respiratory therapist that does asthma teaching and education. We have a yoga program, an agility program. We have nurses from the or students from the College of Medicine, pediatric residents. It's part of the residency program. We have the College of Nursing, College of Kinesiology, rec students actually this year that's doing their practicums with us in the clinic. And so the services certainly has expanded. We've waived the referral system through a family physician because that's the way you get to a pediatrician for most places in Canada, I think certainly in Saskatchewan, and it's direct access. We've gone from seeing few patients a day to needing to see more patients in a day. We've gone from seeing patients 3 days a week to 4.5 days a week, and that's because there's one pediatrician, but certainly that doesn't include the other services that are working with us. The other important role was which ties in with access, and I think with the number of patients coming back to us. One of the things that I want to mention is our follow-up rates is quite high, and we see patients quite frequently in follow-up. One of the things that I've learned is that the children and youth that we see have social ages that far belie their chronological ages. And things change all the time in the lives of children, and so more frequent follow-up affords us the ability to do interventions as they come up, rather than seeing patients every 6 months. Oftentimes we'll see patients every 2 weeks, or every 3 weeks, or every 4 weeks. Not all our patients, but a lot of our patients. Relationships are absolutely important, and it was one of the goals, was to establish relationships with the infants, children, and youth that we see, with the families, with the community. We've immersed ourselves in the community. We attend graduations, we attend powwows, we attend parent-teacher meetings, and we really are part of the fabric of the school. I talked about the increased services, and then lastly, education was one of the things that we were going to look at. We were there to be a resource to families, to the education system. In fact, we've done education sessions for learning assistance teachers, for certainly in the ministry, with the social workers in terms of the children who go through the foster care system. And really looking at ourselves as a resource, and we're being utilized a lot more. So in terms of outcomes, I think that we're certainly achieving quite a bit. The other point that I want to make is when we look at the determinants of health, and certainly on the Canadian list as the list that's written up by Dr. Raphael, which is the one I was looking at, there's 14 determinants. There is no way that I can believe or that I can expect to effect change in health in a short period of time if I'm looking at that list of determinants. It is long-term, and it means we have to look at, even when we're doing research, we have to look at, the many influences of well-being. In terms of challenges, I'll say this, certainly resources is a challenge, financial resources, and I'm a firm believer in that there's enough resources. We have to reallocate resources. We can use the same money, we just have to do it differently. Certainly human resources is an issue, and we could do with probably at least 4 pediatricians, 4 psychologists, and we can just sort of build on the services. I sort of alluded to it before, we have to stop looking at the solutions as piecemeal. Like I said, there's 14 determinants of health. If kids are hungry, they need to be fed. If there's no housing, they need houses. If their rights are being infringed upon, we need to actually step in and have some lawyer help us with that. Engaging the other sectors. We work really closely with education. We struggle with some of the other sectors. And it's a work in progress. I mean, we've made some gains, but again, it's about working in silos that was mentioned earlier on. We really have to get beyond that. And we have to stop looking at health as if we own health, and education as them owning education. One of the things that I would really that we are looking at, and I would really like to follow longitudinally, is our presence in the school, the effect on school dropout. If we look at the predictors for school dropout in kids, it is things such as math scores, reading scores, but behavior and absenteeism are 2 of the big predictors. And so we really have to, I think that we can, just sitting and thinking, I mean, a kid who has social anxiety, who refuses to go to school, if I'm there and I recognize that, and if we can manage and treat that, we're going to get the kid in school. So how can we not make a difference in some way, shape, or form on school dropout? Last thing I want to say is mental health, children's mental health. 90% of the patients that I see come to me because of mental health, behavior, or developmental issues. And I think that we do a shoddy job at addressing children's mental health and behavior. Not every child has a mental health diagnosis, but they certainly struggle with mental health issues, and there's a huge stigma attached to that, and that's something that we really, I feel that we do address, but we can do better at that. Thanks.
But if you wanted to describe, comparing to the dream of Dr. Julien, and for your organization, what kind of difficulties are you facing? Well, what I would call the daily difficulty, it's always to keep in mind why we are here. It's, you know, with all kinds of interventions, it's easy to lose sight of that, and especially with all what we have to do. And we're thinking about also about vulnerable families that are surrounded by different systems, protection, social and health services, and so on and so forth. So to always concentrate on the reason why we're here and how we can better help and accompany this child, this family. So I think it's one of the daily challenges that we are faced with. We said it earlier, there are a lot of determinants, a lot of rights which are being violated. So how can we establish some priority? This might be the first step that we should carry out. And then how do we all work together around these children? You know, we all feel very concerned and committed to them. But also we are working for an institution, whatever it is. We also have to deal with the reality. We've spoken about silo and try to get rid of the separation between the various disciplines so we can work together in a much more efficient way, whether we are working in the field of education, of social protection, or social pediatrics, is how we feel around this child. So that requires some creativity and also giving up or letting go of some of each career sector or professional sector. And sometimes, you know, it might be destabilizing if we feel that somebody from another sector is coming to play in our yard. So we have to accept that we are working on an equal footing basis. And, you know, sometimes as a social worker, it's not always easy to accept maybe a physician coming in, or for a lawyer to accept a social worker or whatever. So to really see who is the most significant help and how we can articulate this and work together, which I think maybe is one of the main challenges, and the other challenges is sustainability, to make sure that we continue to work so that the method developed by Dr. Julien will live on. I think that's what it's at the heart of this. Well, our difficulty is the challenge mentioned by the minister this morning, is to integrate both social services into health services and vice versa. But in the academic hospital, it's not the situation, the case, the attitude. So we have a lot of difficulty to move forward. The other obstacles that we had at the beginning, where we found some ways to move ahead, now we don't have any problem to make some connection with various community organizations, and they're all very happy to have medicine students and residents, because they want to teach something to the doctors and physicians who are not aware of what they should be aware of. But we are not yet really understood in our own building. So this is really an issue that we have, and for which we haven't found any solution yet. Ms. Lyman?
We, of course, have no problems. Because we're eternally hopeful. I'm going to talk about two different kinds of problems. I'm going to talk about one simple example that distresses me as a nurse, is that the nurses want to be more like doctors, and the doctors want to learn social pediatrics, but I can't get the nurses to see that this kind of engagement is actually part of our vision for the profession. So where everybody isn't in agreement that this work produces outcomes. So that I think is a continual challenge for us. And I agree fully with the idea about people's notions of research, because we were very much at the beginning, we did not measure things because our community partners, just like Dr. Mehta described, says we do not want to be objectified in research. We do not want to have someone else tell us what our problems are. So the model we used was a very much of an engaged model, and now they say, and this is what happened with our medical legal, I'm pointing at you folks as medical legal people, they said, can we get a research grant so we can keep the conversation going to involve the people we need to involve? So in fact, the research has become a tool to keep people engaged. That's one way we've used it. So those are some of the challenges, and of course people have different ideas about research. But I think the problem now, that because we started principally with younger children, although we didn't exclude older children, it just, the initial partnerships were with preschools and daycares and young families. We have, in the last year, some of you may have read in the paper, we had a crisis in one of our neighborhoods with young teens, 12 to 15-year-olds. We've been working with them. And it hit a place where this is not for the media, that there were 24 children who signed a suicide pact. And of course, there were all kinds of people engaged in trying to mobilize supports and address this issue in the community. So the challenge is that we know the representative for children and youth in BC has done some excellent reports and analyses of who are the children at risk for suicide, who are the children in care, what is their profile. So she has mapped out why it is, not why, but that there are way too many Aboriginal children in care. She's mapped out the key features. So one of the key features for children who are likely to attempt or be successful at suicide is lack of connection with school. So if we don't keep those children engaged and feeling that school is their place to learn and develop, then we're putting them at risk for a very serious health outcome. So our conversations have been with, and these would be children who would be excluded from school because of unacceptable behavior, or children excluded from the community center for unacceptable behavior, or excluded from other places. So when you start taking children away from the places that have the greatest potential to engage with them, we create a problem, and that is a problem we're trying to figure out. But we also have an idea that worked with younger children. So one of our community partners runs community programs in the summer for children in the neighborhood, and there were children who were not allowed to go because they are the children that Adele described this morning, who poke everybody and don't wait their turn, and they're too much for a 16-year-old camp counselor to handle, so those children couldn't come. So here we have the children who just stand to derive the greatest benefit, the ones that are being told they can't participate. So the community we came up with this idea of many of the children were Aboriginal, but not all. So that we were using a learning circle model. So the idea was that the community said, well, we want the 12 and 13-year-old children to develop skills, like our children might have learned to teach swimming or be a junior counselor. So we'll teach these 13-year-olds how to be mentors for these 8-year-olds. And most of them already know it because their brothers and sisters are poking them all the time because they grew up, they already know how to handle that behavior. So they created a project where they demonstrated they could include the children that people thought were difficult to include and at the same time mentor the older sibling, older children and da-da-da. So it's that kind of creativity that creates solutions for us. The second thing is that community organizations, when I say community organization, I mean these nonprofit organizations, don't have the same bureaucratic constraints that we've discovered institutions like hospitals and schools do. So they can say, well, that's a good idea, let's try it. Whereas bigger institutions can't make a decision here all the time, but they can say, well, let Dr. Metter try it, or they can deploy our resource. So capitalize on the resource that they bring and try and show the example that might work well in a bigger context. So it's mobilizing working within institutional constraints is sometimes a challenge, but there's always somebody who sees the opportunity, I think, if you present it properly.
Maybe if you have questions to ask to our speakers. Dr. Julien. I just wanted to intervene because I think many questions have been raised here, and there are very important questions. Later on, I will speak about the importance of thinking outside of the box and to relook at our experiences, social pediatrics. And in this field, I'd like to go on with this discussion. When we speak about the various initiatives you have referred to, that we have inspired, but they also in return inspire us. But maybe if we look at the model of social pediatrics that we have set up, it is a model that actually took its root in the communities, and it was actually built by the communities. We find, the similar elements in all the projects here around the table, but what we did is we actually, took root in a given community with few means, and then we let things grow by themselves. We just invited people to join us, so it really started this way. Today, well, it has, of course, evolved, and it has increased. It's a social enterprise or social undertaking. Maybe this is something we could define as such. And it has an educational aspect. But the training, the education, we actually took it from the community. And we actually made accessible both integrated medical services, so around the physician, a lawyer, the police services or forces, and the school. Well, schools were some of the first partners. They are really the first external partner that helped us and also provided access to our services. So schools have played a very important role. But from a small model that was born in a community that today can inspire policies and practices. And as it has evolved over the last few years, we have some other models that have been designed and developed. They are a bit different from the one we started, but still in Gatineau, for instance, you had a pilot initiative that was managed by the youth center and the social and health services. They wanted to really, have more reaching out services. And there are two projects right now that are connected to a daycare center. It's called Family Homes, and some other projects that are in the social housing. And this model is evolving, but based on local needs. And also the involvement of the population around these models is very important. And this is what is taking root. This is some kind of a viral spreading from one community. Another one was interesting. For instance, in Montreal it was Hochelaga, Côte-des-Neiges, and then Trois-Rivières, Gatineau, Saint-Jean, Quebec, Lévis. So it was spreading, some kind of let's say, a viral epidemics of what we developed. And so right now, we are dealing with universities to help us to provide a much broader training. So there are several models, and we have this, what I call this viral model here in Quebec, which is influent, which has some influence. Now, what about the obstacles and the barriers? One of the major difficulties we are facing is the fact that, well, the way we look at things, our approach compared to bigger systems, it has brought up some conflicts, and it still is the case. Sometimes when we look at a family, well, the first thing we do is not to judge them. And we really make a conscious effort not to judge these families, because if you start judging them, then you already have an idea that is already made up in your mind, and you will not be able to provide them with the best tools. So when you are confronted, with professions that are rigid, or some rigid institutions that have no flexibility, that work from the outset, you might have some conflicts. The way we look at things are different. When you have, for instance, CAS, a Children's Aid Society, or other institutional authorities and bodies that try to get involved, well, they're going to bring some rigidity and might create potentially some barriers and even violate some rights. So we have a different way of looking at things which creates those obstacles. And also people think we are competing with the system. No, we are not. We are complementary. And the other aspect that is also an obstacle, but at the same time it's an important, is this idea of not taking charge of, not taking, we're not responsible for these people, because if you take their responsibilities away, then you take the little power they had left. So this is not the idea. And I've learned this, in the larger institution, in the social services or a hospital, when they tell you, don't worry, we'll take charge of you, we'll be responsible for you. And no, this is not health maintaining, because you take away the power from these people. So that's why the question of empowerment is extremely important in social pediatrics. And all what we're trying to do, and I can hear it from the panelists as well, is that we are here to bring some expertise so that they can use it, so that they can benefit from it and to have better lives. So those were some comments I wanted to make concerning the models that are being deployed. Well, maybe I'll come back on the conclusion for that, and I'll let you continue. But there are a lot of similarities. We just have models that are being deployed differently, but they are similar. And it's important in symposium like this one to be able to exchange and to influence each other to make this model evolve all the time.